Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on data for long-acting injectable PrEP, featuring Dr. Jason Schafer, who is a professor and vice chair at Jefferson College of Pharmacy, Thomas Jefferson University in Philadelphia, Pennsylvania. He'll take us through a case study of a patient who is interested in long-acting injectable PrEP, and we'll explore the latest efficacy and safety data from the major clinical trials that led to the approval of cabotegravir for PrEP. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Schafer.
Welcome to this Key Decisions in HIV presentation. This presentation is titled Data on Long-Acting Injectable PrEP. My name is Jason Schafer. I'm a pharmacist, professor, and vice chair at the Jefferson College of Pharmacy in Philadelphia, Pennsylvania. Let's begin our discussion today with a case study. 35-year-old cisgender man who has sex with men is having difficulty adhering to daily oral PrEP. He is interested in switching to long-acting cabotegravir, but has concerns about injection site pain or other injection site reactions. He is HIV negative, at least upon his most recent test results. His antigen antibody test was negative, as well as his HIV viral load being undetectable. He is immune to hepatitis B, doesn't have hepatitis C. His renal function and liver function appear to be within normal limits. His CBC is normal, his BMI is 26, and his A1C is 4.9%. Cabotegravir was recently FDA approved for pre-exposure prophylaxis in at-risk adults and adolescents weighing at least 35 kilograms to reduce their risk of sexually acquired HIV infection. When we use cabotegravir for PrEP, it should be initiated as 2 injections administered 1 month apart, and then every 2 months thereafter. Patients can either start with cabotegravir injections immediately, or they can take an oral cabotegravir lead-in for 4 weeks just to assess how well they tolerate the medicine. In the clinical trials leading up to the FDA approval for cabotegravir, the oral lead-in suggested that patients tolerated the medicine extremely well. And that's why the oral lead-in is just optional when it comes to PrEP for cabotegravir. With cabotegravir's approval, we've increased our options for pre-exposure prophylaxis. For a long time, our options for pre-exposure prophylaxis have been limited to oral tablets, either TDF-FTC or TAF-FTC. And with the expansion of our options to include this injectable medicine, we've really increased our ability to almost tailor our pre-exposure prophylaxis for individual patients. We also know that there are other options emerging for PrEP as well with different types of delivery systems for our PrEP medications. These include intravaginal rings, as well as implantable devices that would release medicine over time. And why do we need these options? Well, it's become clear that the daily pill is just not suitable or perhaps desirable for everyone in terms of their HIV prevention strategies. And if we have more options available for patients, that will increase access, and it's going to increase use for people at risk just by having more options for them to choose from. And we know options are important for all patients who may be at risk for HIV infection and want to be on PrEP. Looking at this particular survey study, we see that there's just a variety of potential preferences for patients who are at risk for HIV infection and may use PrEP, whether it's condoms, pills, injections, or perhaps implants. So providing options for patients that really meet their priorities. And in this study, the priorities for patients when it comes to PrEP were things like convenience, duration of protection, and privacy. And that can mean something different to every patient. So having the options to meet those priorities for patients will, again, increase PrEP use and increase our ability to really tailor our PrEP prescriptions for individual patients. So when we talk about cabotegravir, it's important to understand the data behind its FDA approval. And of course, there were 2 very large studies that led up to the FDA approval of cabotegravir. both HPTN 083 and 084. These were international randomized double-blind studies looking at the efficacy of cabotegravir as a long-acting injectable medicine in comparison to TDF-FTC as an oral medicine for pre-exposure prophylaxis. As a review, HPTN 083 included MSM and transgender women at high risk of HIV infection. Over 4,500 individuals were included in HPTN 083. In HPTN 084, the companion study, they included sexually active cisgender women at a high risk of HIV infection. Over 3,000 participants were included in that particular study. And again, these were identical studies, whereas in step 1 of the studies, patients received an oral lead-in approach with cabotegravir given orally or matching placebo. And in the other arm, patients receiving TDF-FTC or matching placebo for the first 5 weeks of the study. Patients then moved on to step 2, where they either received long-acting cabotegravir injections plus an oral placebo, or they received a long-acting injection placebo and oral TDF-FTC as a daily medicine. Now, patients really didn't make it to step 3. Step 3 would have been kind of everybody moving to the TDF-FTC oral daily regimen. And they didn't make it to that step 3 because the Data Safety Monitoring Board reviewed the data early on and found that there was a clear indication of superiority of cabotegravir in terms of its efficacy in preventing HIV infection in comparison to TDF-FTC. And we can see the data with regards to the difference between cabotegravir and TDF-FTC from both of these studies. In HPTN 083, we know that there were initially thought to be 13 incident infections in comparison to 39 incident infections amongst patients receiving TDF-FTC. Those 13 infections in the cabotegravir arm, one of those infections was readjudicated to a baseline infection. And so really there were 12 incident infections amongst patients in the cabotegravir arm. In HPTN 084, a similar story. 4 patients initially thought to have incident HIV infection in the cabotegravir arm. One of those, again, readjudicated to a baseline infection. So really 3 incident infections in the cabotegravir arm versus 36 in patients receiving TDF-FTC. Again, in both circumstances, 083 and 084, the data met superiority in terms of cabotegravir being superior to the TDF-FTC daily regimen. And so to really understand the efficacy of cabotegravir in terms of the 083 study, it's really important to look at the individual infections that occurred in this study. And on this particular slide, you can see that the infections were broken up into different categories. Remember, there were 4 baseline infections and 12 incident infections in the cabotegravir arm. Those 4 baseline infections are in group A. And so the 12 incident infections occurred in groups B, C, and D. In group B, there were 5 infections, and these occurred after prolonged delays in cabotegravir dosing. Now, in 2 of these patients, they were actually converted to oral TDF-FTC after some of those prolonged delays in cabotegravir dosing. In others, they may have been lost to follow-up and really weren't started on either cabotegravir or that oral TDF-FTC. In group C, there were 3 infections, and these occurred during the oral lead-in phase. And patients had HIV infection prior to really starting their cabotegravir injections. In group D, there were 4 infections. And these 4 infections occurred despite on-time cabotegravir dosing, and really those patients achieving target levels of cabotegravir. Now, importantly, of those 4 infections that did occur despite on-time cabotegravir dosing, 2 of those individuals did have evidence of integrase inhibitor resistance. Resistance was also identified in a couple of other infections in this study, one in which occurred at baseline, and 2 that occurred in patients that had infection during oral lead-in. Another important piece of information to take away from this study were that there were delays in the diagnosis of HIV infection. This was particularly true for patients who were actually on study medication at the time of their diagnosis. It appears that being on medicine may actually delay the time to positivity for rapid antibody tests as well as antigen antibody tests. And so moving forward, it may be necessary to use viral load testing as a more sensitive marker to diagnose people with HIV infection who are receiving PrEP. Among the 16 infections that occurred in individuals in the cabotegravir arm, 7 of 16 had resistance-associated mutations. 5 had integrase resistance mutations, and those resistance mutations we do expect to have influence over the activity of dolutegravir and bictegravir as well. There were 42 infections that occurred amongst individuals in the TDF-FTC arm of the study. 39 of those were incident infections. 37 of those 39 infections were in non-adherent participants or in those with suboptimal drug concentrations, indicating that when people did take TDF-FTC well and were adherent to that medicine, it was very effective at preventing HIV infection. However, as we've learned over the years with FTC and TDF, adherence to that medicine on a daily basis is challenging for some individuals. 13 of the 42 individuals with HIV infection did have resistance-associated mutations. Some had resistance to non-nuke resistant reverse transcriptase inhibitors. Others had resistance to both NNRTI and NRTIs, and some had resistance to NRTIs only. In looking at HPTN 084, there were only 4 infections that occurred amongst individuals receiving cabotegravir. Again, 1 of those infections occurred at baseline, and 3 of those were incident infections. Importantly, there were no major INSTI mutations that were identified amongst individuals who acquired HIV infection in the cabotegravir arm. However, similar to HPTN 083, HIV detection via routine diagnostic assays was delayed in patients receiving cabotegravir. And so again, viral load testing may be the more sensitive assay that will be used moving forward in detecting HIV infection in individuals receiving pre-exposure prophylaxis. Now, in terms of adverse effects in individuals receiving cabotegravir in HPTN 083 and 084, it's important to talk about injection site reactions and weight changes. In terms of injection site reactions, they were common, particularly in HPTN 083. Almost 82% of individuals within the cabotegravir arm reported an injection site reaction. Importantly, though, these injection site reactions were relatively mild and decreased in incidence throughout the duration of the study. In terms of their severity, permanent discontinuation for injection-related adverse effects was very low, only 2.4% of participants. In HPTN 084, injection site reactions were reported at a lower frequency, 32% in those receiving cabotegravir. And again, relatively mild in terms of the severity of the reaction. Only 7% had grade 2 or greater injection site reactions, and no discontinuations occurred due to injection site reactions in 084. In terms of weight changes, weight change did occur amongst individuals in both 083 and 084. In 084, there was initial weight increase that was statistically different in the cabotegravir arm, but really overall median weight change between intervention groups throughout the study period was very similar. 2.4 kilograms per year in those on cabotegravir versus 2.2 kilograms per year with FTC TDF. When it comes to injection site reactions, it's important to understand what the guidelines say in terms of management. We know that injection site reactions are frequent following cabotegravir injections. We also know that they're generally mild and really last only a few days, and they occur most frequently after the first few injections. And patients can be provided with some proactive management advice for these particular injections or injections moving forward. They can take over-the-counter pain medication within a couple of hours before or even soon after the injection and continue as needed for 1 or 2 days after the injection. They can also apply a warm compress or heating pad to the injection site for 15 to 20 minutes after the injection when they arrive back home after their appointment. This can help mitigate or at least reduce the injection site reactions that patients experience. And so moving back to our case, again, we have a 35-year-old cisgender man who has sex with men, and he's having difficulty adhering to daily oral PrEP. He's interested in switching to long-acting cabotegravir, but is concerned about the injection site pain or injection site reactions. What should you tell your patient who is concerned about injection site reactions with cabotegravir for PrEP? Injection site reactions are common, but mild, and rarely lead to drug discontinuation. And now we'll hear from a patient who is receiving PrEP and interested in long-acting cabotegravir.
The biggest thing that I learned about PrEP when you take it is that it's an amazing drug. It gives you a high efficacy of preventing transmission of HIV. But at the same time, it doesn't mean that you get a get out of jail free card. Like, you still have to be cognizant of your sexual practices. You need to still practice safe sex. It wasn't I can do whatever I want. It's a magic pill. But at the same time, it gave me comfort knowing that I'm doing everything I can to not only keep myself safe, but keep others safe. The idea of a newer medication on the market, a once monthly injectable, was kind of fascinating to me, very exciting. I look at all the other disease processes in medicine and all of these other, emerging infections or these autoimmune diseases that are doing these injectables every 1 month, every 6 months. And I thought, this is kind of groundbreaking to have a once monthly medication that would cover you for that month. And then you just go back, get it again. And it kind of takes away the stress of taking a once daily pill.
And so to summarize some of our key take-home points, long-acting cabotegravir joins FTC-TDF and FTC-TAF as FDA-approved options for PrEP. In comparison with FTC-TDF, long-acting cabotegravir reduced the risk of sexually acquired HIV in at-risk adults in both HPTN 083 and 084 trials. Long-acting cabotegravir is safe and well-tolerated, but will cause mild injection site reactions that rarely lead to drug discontinuation. Go online for more CCO activities on key decisions in HIV care.
Thank you to Dr. Schafer, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you, and have a great day.